Welcome to the next session. This will be managing heart failure in the Fontan-Kreutzer and timing for replacement therapy. So our first speaker is Dr. Anita Saraf, who's an MD, PhD, and one of our adult congenital colleagues.
Thank you, Kirsten. Welcome back, everyone. And thank you for being in attendance and for your enthusiasm for this conference. We really appreciate all of you and the support that you've provided us in many different ways. So I'm going to talk a little bit about medical therapy and our approach to a patient who is becoming more and more symptomatic over time. So here I have an example of one of a popular Fontan patient, somebody that everybody knows and has heard her speak in quite a few conferences, Megan Roswick. She has HLHS, and she's determined to live her life to the fullest. She skydives, she skis, and she is very active on social media. And she is, one could say, a perfect example of a healthy Fontan or even a super Fontan. And then at the other end, you have patients who have Fontan circulation and are awaiting a heart transplant, have protein-losing enteropathy, have plastic bronchitis, or have symptomatic heart failure, or sometimes we even lose a lot of our patients in this long journey of Fontan operation. And in many cases, in many circles, this is called Fontan failure. And going between Fontan failure and a healthy Fontan is a long process, and the one that we don't really understand too well. So developing this Fontan failure happens over the lifetime of the Fontan patient. And everybody likes to start thinking about the heart and the heart failure aspect of Fontan failure. But really, the heart is more susceptible to damage and further downstream consequences right from the embryonic development of this particular child. So when you think about a single ventricle, there are multiple different factors that can contribute to single ventricle anatomy. And this includes DNA mutations, epigenetic modifications, as well as the environment within the uterus for the embryo. And different factors work together to create the single ventricle physiology. Within the DNA mutations, there are different types of DNA mutations that have been implicated, including Notch and TBX and NKX2.5. And all of these mutations are not really specific to cardiomyocyte development. They actually influence the development of a whole bunch of different organs, including endothelial cells and blood vessels, cardiomyocytes and other types of cells within the heart, the lymphatic system, the liver, and the brain. And after the child is born, they go through a series of operations, and then they have to go through an operation that changes the physiology and the way blood flows and circulates through the body, and this is the Fontan physiology. And you have heard about this many times through many different talks this morning, where the pressures within the circulatory system are very different in the Fontan physiology versus a normal biventricular physiology. As the blood exits the heart, it experiences very high pressures in the aorta, the descending aorta, and as the blood circulates to the periphery, these pressures fall. And as the venous return of the blood into the heart continues, these pressures fall further, but you don't see that in the Fontan circulation, where these pressures continue to be significantly high. And as a result of these high pressures, what the rest of the body sees is an increased pressure within the liver and within the portal circulation that has consequences down the line for a Fontan patient. So when you think about a symptomatic Fontan, it is easy to blame just the heart and to look for signs of heart failure. But if you've learned anything through this morning, it's that it's never just the heart. There are so many different organs that are involved in this Fontan failure physiology. So with the heart, of course, we see cardiomyopathy, we see heart failure, valve failure, as well as arrhythmias. But then there's the liver, and we had a great lecture on FALD. Ascites, liver cirrhosis are all implicated in some of our patients who are awaiting transplant. There's portal hypertension that presents itself as varices and thrombocytopenia, pulmonary hypertension, We had a great lecture on how our patients continue to struggle from a psychological perspective, and there's also huge evidence of how cognitive and executive function is also affected in our patients. Of course, kidneys are always in the picture whenever the heart is in the picture. You have renal dysfunction as well. And of course, we had a wonderful series of talks that talked about various factors that change the way the Fontan conduit behaves over time, either because of the formation of thrombus within the Fontan conduit itself, or because of the formation of collaterals because of a difference in pressures. And last, but definitely not least, is the lymphatic circulation, and we're going to have a great talk about that later in this series as well. So when we think about all these different ways in which a symptomatic Fontan patient can present to us, what makes it even more challenging is that they don't necessarily present the same way as children versus as adults. So as children with Fontan circulation, when they start having symptoms, what is more evident is they have plastic bronchitis, they may have some arrhythmias, but all of these incidents of arrhythmias and other types of PLE become more evident in the adult population. FALT, for example, Fontan-associated liver disease, is definitely more ubiquitous in the adult population as compared to a pediatric population. And we are very aggressive at our center to monitor for Fontan-associated liver disease, as was indicated by Dr. Malik. So it's not surprising that given that this disease involves so many different organs, that traditional therapies that are used in heart failure in non-congenital heart disease patients don't necessarily work as well in our Fontan patients. So in this paper by Roche et al., they mentioned that there is really no great evidence that supports the use of beta blockers or ACE inhibitors in this population, and definitely not as robust as we see in some of our traditional patients, adult patients who have ischemic heart disease. There's another paper that came out that might explain why this is so. Could it be that the heart failure that we see in our Fontan patients is just completely different, or in many ways different, than the heart failure that we see in ischemic patients who have heart failure? So this is a paper and a study that was from Colorado by Shelly Miyamoto's group, where she looked at actual myocardial samples from 3 different types of patients. So this is a normal biventricular functioning patient and the explants of their hearts, and they compared them to non-failing single ventricle patients as well as failing single ventricle patients. And what they saw was that the non-failing biventricle patients and the non-failing single ventricle patients metabolize different factors within the mitochondria completely differently from each other. And over time, as the single ventricle patients start developing heart failure, these differences in metabolic outcomes become even more profound. There's mitochondrial dysfunction that is more profound in our single ventricle patients, not just when they have heart failure type symptoms, but much before that, in addition to the type of immunological responses that we get from these patients. So these authors concluded that heart failure in a single ventricle patient is affected significantly by the differences in the way energy is metabolized within the mitochondria of these single ventricle patients. And that could be a basis for sort of considering, or perhaps considering, that the therapies that we so commonly use in our chronic heart failure patients, or adult patients, may not necessarily work as well in our Fontan patients. However, this is all we have right now in terms of evidence, and all of our Fontan patients continue to benefit in some ways through the various therapies that we give them, including beta blockers and ACE inhibitors. Perhaps there isn't enough evidence to support this because most of the trials that were tried in these patient populations were really small, very small patient size in terms of patient population. The genetics and anatomy of these patients is also very diverse, and that adds a significant amount of confounding factors to these studies. Furthermore, I just mentioned also the fact that mitochondrial disease and cardiac dysfunction is a lifelong ailment that affects these patients, and we are only looking at the efficacy of these drugs over a few weeks or maybe perhaps a few months, and we are not giving them sufficient time to benefit from these therapies while we do randomized controlled trials. Furthermore, when we looked at retrospective studies or studies that are observational, multidisciplinary centers don't necessarily follow a uniform prescription methodology. There's variability in the rate at which these drugs are prescribed, ranging from 7% to 100% at these different centers, and therefore these outcomes might be different. So what really is the evidence of the guideline-directed medical therapy in Fontan failure as we understand it? So beta blockers, all of our ischemic heart disease patients get beta blockers even before they leave the hospital. It has great antiarrhythmic effects. However, in our Fontan patients, we need to be a little more careful in giving these patients these drugs when we know that they have sinus node dysfunction or when we know that they can have reduced exercise capacity. Studies have shown that beta blockade decreases exercise hemodynamic response by lowering the blood pressure and decreasing chronotropic response in these patients. ACE inhibitors are great medications. They modulate the renin-angiotensin-aldosterone pathway, regulate the blood volume and atrial pressures. However, short-term treatments of these medications in our Fontan patients has not necessarily shown that kind of benefit and has not shown a difference in exercise capacity, ventricular function, or arterial stiffness. Furthermore, in our young Fontan patients who are at childbearing age, adding an ACE inhibitor or an ARB might be detrimental, as they have teratogenic effects on the fetus as well, and our patients may not necessarily know to stop these medications in time. Aldosterone receptor antagonists such as spironolactone also act together with diuretics in eliminating water and sodium from the body. And they have not really been shown to have any detrimental effects in our Fontan patients. And in fact, there have been few case studies where they have had some anti-inflammatory benefit with protein-losing enteropathy. And lastly, diuretics, which are commonly used in a lot of our Fontan patients and provide symptomatic relief to our Fontan patients with heart failure. 50% of adults with Fontan circulation are on diuretics, as was shown through a multi-center trial. However, independently, the use of diuretics was also associated with a 17-fold increase in transplant and death. So they need to be sparingly and wisely administered to our patients. So does treating a symptomatic Fontan patient then require for us to think a little bit outside the box? So what are some of the agents that have actually shown some benefit in our patients? The phosphodiesterase inhibitors and endothelin receptor blockers, pulmonary hypertension medications, have shown some benefit in our Fontan patients. This was a multi-center meta-analysis of 9 randomized controlled trials that was earlier published in 2019, where they looked at 381 patients who were on these pulmonary hypertension medications. And they concluded that there was a significant improvement in Fontan hemodynamics, reduction in NYHA class, increased 6-minute walking distance by 134 meters, and improved oxygen consumption during exercise. However, there was no significant benefit in mortality or in NT-proBNP levels. Additionally, more recently, we have seen the results of the FUEL study, where they administered sildenafil for about 26 weeks in about 400 Fontan patients. And this medication as well has shown some improvement in various exercise parameters, although not all parameters showed a significant benefit. So as per the AHA-ACC guidelines, administering these medications in our Fontan patients has a Class 2A recommendation, whereas the European Society gives it a Class 2B recommendation citing limited data. However, I would like to point out that there is increasing evidence that there is some influence of these medications on mitochondrial function, ROS production or reactive oxygen species productions, and could have overall pleiotropic effects in improving cardiac function by really targeting some of the cellular mechanisms by which Fontan failure takes place. What is also notable is that while these are recommended as Class 2A guidelines, they are not very widely used. Only 5% of patients in a multi-cohort study from the UK showed that they were being used by patients with Fontan circulation. Next, I would just briefly like to talk about the non-pump failure of Fontan failure, which is the circulatory failure. Understanding portal hypertension and circulatory failure is just as important as understanding heart failure in these patients. In the study from Emory that came out in 2013, they looked at varices, ascites, splenomegaly, and thrombocytopenia, and created this VAS score and showed that a VAS score over 2 had significant correlation with hepatocellular carcinoma, transplantation, and death. And more recently, in 2021, they investigated the use of vasoconstrictive therapy in these patients by administering either oral midodrine or intravenous noradrenaline, and showed that at a median interval of 1.7 months, various parameters did improve, and hospital admission did decrease from 4 to 1 at a 21-month follow-up. Unfortunately, these patients do have high mortality, and 60% of these patients did die at the end of the study. Lastly, I would like to talk about protein-losing enteropathy, which we see commonly in some of our adult Fontan patients. There has been a multi-drug approach to solving or addressing these issues that come up in our Fontan patients and involve the use of reducing congestion by using furosemide and spironolactone, replacing lost protein, reducing inflammation by using budesonide, low molecular weight heparin, and to some extent spironolactone, reducing lymph reduction, and then modulating lymphatic and vascular tone by using midodrine and dopamine. However, I think we really do need to think outside the box when it comes to these patients and think of next-generation therapies, and some of the new ideas that have been used out there to address these patients include the use of oral positive pressure devices. This is a study that is being led by Dr. El Said at our center, where he's looking at these OPEP devices to see if he can improve overall outflow through the heart of patients with Fontan circulation by the use of these devices over a very short period of time, just a few weeks. And there are other devices as well, including the externally applied compression therapy, where they provide pulsatile compression pressures to the lower extremities to improve venous blood flow to the heart. And these studies are continuing and ongoing, and hopefully will yield some exciting results in our patients. So in summary, transition from healthy to a failing Fontan can be subtle and can be an extended process. Symptomatic Fontan patients have cardiac as well as extracardiac symptoms. Genetic, epigenetic, and environmental causes of single ventricle anatomy can also influence non-cardiac organs. Etiology of Fontan pump failure can be very different from traditional heart failure, and guideline-directed medical therapy may not necessarily work as well in these patients. Hence, we need to keep an open mind and think outside the box when it comes to using novel drugs as well as novel approaches to finding new cures for these patients. And thank you.